sharing my for today, and let's see how we proceed. So let's have an interactive session, and maybe we can share our ideas and thoughts as we go along. Um, can everyone see my screen? Is it visible?
Yes,
Yes,
ma'am.
Rutula, go ahead.
So coming to palliative medicine in non-oncology or non-cancer patients, it's okay. So basically, we all know this definition. Palliative medicine is basically an approach, is described as an approach which improves the quality of life of patients in adults and in children and their family members who are facing problems with life-limiting illnesses. Now, this they said should be done by early identification of all the suffering, correct assessment of all the symptoms, which can be physical, psychological, or spiritual as well. Okay. So, by going by the definition, what we understand is that it is a continuum of all that is going on. It should go hand in hand with the ongoing treatment for the patient, and it continues even beyond the death of the patient into bereavement care. Now, initially, it was thought to be what do you say, kind of a linear thing where palliative care was usually initiated mostly during the end of life care or in advanced stages of the disease, where disease modifying therapy was stopped or was at the minimal best. But now it has progressed to going side by side or hand in hand with the disease modifying agent. So we are ideally supposed to be involved right from the diagnosis to their death and beyond the death. um, Showing a similar pattern, which we can then make it into a bow tie model where it is fully integrated with your disease management and can either proceed to rehabilitation into survivorship or end of life care into bereavement. Now, as palliative care physicians, we need to have certain competencies. This is actually described in the UG curriculum in Canada, but extrapolating it to our base, it can be described as that everyone should know what a palliative care approach is. They should be able to address and manage all the symptoms, including pain, fatigue, anxiety, breathlessness, cachexia, anorexia, etc. Uh, we should all be able to participate in care for a dying patient and helping their families. So here it means that you should be able to identify their signs of approaching death. You should be able to describe what common signs of natural dying process are, and we should be able to communicate or help prepare the patient, family members, and caregivers during the death, during the dying process, and even with the care of the body after the death. So along the way, you should be able to address the psychosocial and spiritual needs. There are multiple tools which are available and how to manage them. Then help them make the end of life care decisions, which are within the bioethical framework of your institute or of your region where you're practicing. Here, we can put into if effect the advanced directive if that is being done in your area. Then communication becomes a key, not only with the family members, but with the patients as well. And always remember that any source of suffering is always multimodal, multidimensional. So there can be physical, social, psychological, or spiritual aspect to the suffering that the patient is going through. And also be aware, self-aware of all the things that are going on, because uh, patient death is always traumatic, even if we try to deny it, and it takes a toll on our health as well. So be self-aware about the burden that you might be having, be self-aware about the burnout you might be having, and take a break wherever necessary so that you can give your 100% to the patients who are going to come to you ahead. So coming down to the actual four roads to death. So there is sudden death, which we all hope for, that it is in an instant where we don't realize what is happening. The second one would be more pertinent to the B graph is more pertinent to cancer patients where they have a stable road when they are going ahead with their disease modifying treatment, and they go serially down once that stops being effective, and which eventually leads to death. Graph C is more with organ failures or with end stage organ dysfunction, where there is serial drop in health or functionality as you go along the trajectory, with multiple hospitalization and multiple exacerbations of their disease, which eventually leads to death. Now, why this is important is that as you can see from the graph, with every dip in the functionality or health of the patient, the rise or coming back to health is never back to baseline. It's always lower than the baseline. So what this means is that the patient become unaware of the fact that with every hospitalization or with every exacerbation, their health is deteriorating further, and their functionality is going down, because like this is the new normal. That is what they assume. So this becomes very tricky when you're trying to explain to them that this is also a chronic disease equivalent to cancer, though not because of the stigma associated with cancer, right? Like the diagnosis would itself spell out that, oh, this patient is going to die. That is not so with the non-oncology part. So being telling them about their deteriorating health becomes a huge challenge. Frailty is the one, or graph D is the one which is associated with your aging process, your natural aging process, where the functionality is decreasing. It's low to begin with, but it is decreasing because of the natural aging that is going on. Now, coming to, so where palliative care would be beneficial, it would be beneficial in all the chronic organ system failures, all the neurodegenerative diseases, rheumatological diseases, cancer, we all know. Prolonged ICU illness where it is leading to organ failures and not responding to treatment any further. It even is important as part of geriatric care and frailty management. So all these is where palliative medicine would be beneficial or would benefit in. Now, coming on to the barriers, what do you think are the barriers? So why is it so difficult, especially in non-oncology? So can anyone tell me, just unmute, or you can maybe put it in the chat as well. What do you feel are the a physician's perspective about why they are unwilling to send in the patient for palliative care? What would you think are the reasons? You can type it in, or you can just unmute and ignorance. Okay. One can be that they are unaware of the whole thing. Anything else? Fear of losing a patient. Okay. Anything else? Patient refusal. Don't want to give up. Okay. Patient. Okay. Financial issues. Okay. Anything else? Yeah. So there is still hope that they can do their maximum best. Okay. So uh, it can be basically like they always want to cure. Okay. Yeah, non-availability and unawareness. Okay. So, but from a physician's perspective, they always feel that they want to do their best and always aim for that cure that they are hoping for. They feel like they're giving up on the patients if they are referring to, a palliative care physician. They take it as a personal failure that they couldn't do anything for that patient. lack of knowledge, as you said, there's lack of awareness about palliative care in general and inavailability. Okay. What about caregiver perspective or patient's perspective about why they do not want to go for palliative care? Awareness becomes another thing. Guilt, excellent. Yes, guilt is a major part. And denial, okay. Don't want multiple consultations, okay. Anything else? Yes, okay. So the patient won't want to give up, losing hope. Okay. Okay. So basically, as we discussed earlier, the disease trajectory is such that they feel that अरे अभी तो patient ठीक थे अचानक से क्या हो गया. So because of the disease trajectory itself, it becomes very difficult for them to understand what is going on and to understand the severity of their disease. Then they want everything to be done for their loved ones. So, and as you said, they believe that the patient is a fighter and he will still just still have that willpower to fight it. Guilt, as you said. And again, there's a question of, oh, मैंने अगर ये कर दिया, then what would the other people say? They'll say that I'm not doing my best for my father or my mother-in-law and whatever. So that's what the whole barriers come in. Okay, so now coming to the non-oncological diseases. So I am not going to discuss in details about what diseases are because that is not what the aim of today's lecture is. But we'll discuss the common symptoms in each of the systems. So we'll go system-wise and not disease-wise. So the most common symptoms that the patients present with in each system and maybe the management. And again, the management will be open for discussion. So whatever the doubts may be or whatever inputs that you want to tell, please type it in the chat box and we'll discuss from there. So coming to the central nervous system, the most common diseases which would present in palliative care settings would be dementias, your Parkinson diseases, your brain injuries and stroke. The common symptoms that we see are your seizures, your paresis or plasias. So, mostly in stroke patients, you have your dystonias, dysphagias, and aphasias, right? So, coming to management of each side. So, rehabilitative measures would go a long way in all the non-oncological or cancer patients as well. But specifically in CNS disorders, rehabilitative measures would be your cornerstone of management because they take away a lot of the symptoms and manage a lot of symptoms with that. Now, pain again would be a common symptom because of any plasias, contractures that might be there, or even because of the paraparesis or hemiparesis, there's a lot of pain in the limbs that are involved. So, baclofen or muscle relaxants would help a lot. Any other analgesics? Do you feel that opioids would be beneficial in, let's say, quadriplegic patient? Would you want to use opioid or strong opioid in this patients? Or would you not? Would you just be going for muscle relaxants and let's say NSAIDs or non-opioid management first? Can use, right? So I mean, wherever necessary, you would want to use you want to use opioids for their help. So analgesic should be used as per discretion. So wherever necessary, you would go for a use of analgesics. Anti-epileptics, again, according to your protocol, whichever you're following, according to hospital protocols, you have to give anti-epileptics and you might have to go up on anti-epileptics as well. In patients where it is not getting controlled with the use of any of the anti-epileptics, and newer or recently they've started using cannabidiol. So CBD is used for retractable seizures. Dose, again, the availability and dosing would depend upon what is causing and what how much the patient can tolerate. But that is again another drug in your pocket which you can use if nothing else is working. Then NG feed versus PEG feed, which becomes very controversial. So what would your NG insertion or PEG insertion depend on? Two things. It depends on two things. One is basically your survival, like what do you expect, how long do you expect the patient to survive, and affordability. So these are the two main things that NG versus PEG feeding would depend on. So let's say the patient is fairly affordable, what would you prefer? Like he has insurance and he has there's a good financial background. So what is preferred in what? PEG. So why would you prefer PEG over NG feed, NG tube? Why PEG over NG? The simple reason because it it is more helpful in preventing your aspiration. Just because your sphincter, the esophageal gastric sphincter does not remain patent, so it is more helpful in preventing aspiration, and it is more aesthetically pleasing. Like there's no nose down your nose, there's no tube down your nose, so it's more cosmetically pleasing and aesthetically pleasing. Like peg tube is hidden under your clothes, so no one sees it. So maybe less, yeah. It's both are equally discomforting and comforting. So it depends on patient to patient. But yeah. So this is in a patient who has a good survival time and is fairly affording or non-affording. What about the patient who does not have very long to live in? Like maybe let's say the patient is going to live for the next 3 weeks versus a patient who is going, estimate that the patient won't survive the next 5 days. So what would be your decision there? 3 weeks versus 5 days. 3 weeks, I would still want to do some sort of feeding. So I would still wanted to put in a peg feed or a NG feed depending on what. I mean, 3 weeks you might as well go for a NG tube. In a patient who you estimate won't survive for more than a week, what would be your line of action? NG still, or would you want to give them just IV fluid still, whatever, however long, or what? It becomes a controversial question because some may still want to go ahead with NG insertion. Some may just want to continue with IV fluids and IV feeds if that is going to help. So it depends on patient to patient and person to person as well. So that is helpful. Speech aids I specifically said for aphasias because there are it all depends upon the availability of rehabilitative measures in your area, but there are a lot of speech aids which are computerized or light pointed and all that. So, or simple techniques like blink one for yes and blink twice for no. So but then you'll have to ask them a very direct yes and no question. So speech aids would help in rehabilitation as well. Sorry. So coming to cardiovascular diseases, you have your heart failures, you have your congenital heart disease, which lead to Eisenmengerization and lead to a lot of severe symptoms. So the symptoms mainly are your breathlessness, you have your chest pain or heaviness, you have palpitation, which can be perceived as having a lot of anxiety. There is edema, cough, fatigue, and sleep disturbances. Now, as I said, rehabilitation in all of them across the board. Opioids are necessary here. What are the symptoms that will benefit from opioids in cardiovascular? Coming down back to symptoms. So, in which all would opioids, specifically morphine, help? Breathlessness, excellent. Anything else? Chest pain and to a certain yes, so to a certain level it will help with the palpitations as well, because it takes away the preload. So palpitations to a to a certain extent would be benefited with help of opioids, and cough would benefit from the use of opioids. So there are three symptoms in one tablet, so that is a good drug to have in with you. Diuretics would help with the edema, again with the palpitations and with the breathlessness as well. Beta blockers become a very yes and no. Like it can be used in certain patients, it won't be helpful in others. So according to individual, you'll have to individualize it to each patient. Oxygen support wherever necessary should be used, and it will help with your breathlessness and your palpitations, anxiety as well. Coming to respiratory diseases, so you have your COPDs, ILDs, cor pulmonary, which is eventually because of those two diseases, and pulmonary embolism also present with a lot of symptoms. So again, the symptoms overlap that of cardiovascular. So you have your breathlessness, you have your fatigue, you have chest pain. Sometimes you'll have your cough, fatigue, delirium, palpitations, headache. So again, the managements are more or less the same. You have your opioids and the diuretics, which will help with your pain and breathlessness. And acetylcysteine would help with your secretion. So they help you to loosen out your secretions, which would then be helpful to cough it out or remove it with the help of your rehabilitation. So it helps in that way. Oxygen support would be more benefited in respiratory diseases. Antipsychotics, especially if they are having hypoxic delirium or delirious episodes because of the acute exacerbations, that might be necessary. Steroids are also a part of their mainstay disease management. So steroids are helpful wherever necessary. Um, Coming to hepatobiliary diseases, so you have your liver diseases, that is cirrhosis or failure. So all the signs of liver failure would be your symptoms. So you have your nausea, vomiting, you have pruritus, you have fatigue, weight loss, uh, edema. It can be hemoptysis, melena, or hematochezia. So all of them, all the signs of liver failure would become your symptoms automatically. Then coming to the nausea, vomiting part of it. So what would be your antiemetic of choice here in a case with, let's say, hepatic failure and a lot of nausea and a lot of vomiting? He is unable to tolerate anything. What would become your drug of choice here? Anyone? So anything that is centrally acting would be your uh, drug of choice. So ondansetron, as you correctly said, so anything that crosses the blood-brain barrier and acts centrally. So your 5-HT3s or your dopamine antagonists like um, haloperidol will also work here. So anything centrally acting is helpful. Now, I've written here sertraline. So it's basically used for pruritus. So that would be your first line of management for hepatic reason of pruritus. So sertraline becomes the drug of choice. Um, Laxatives, which laxative would be referred to failure? Anyone? Lactulose. Why? So what is the benefit that lactulose has over the others in hepatic? Bisacodyl can also be given, but it's mainly lactulose because of what does it prevent? So yeah. So ammonia, it does not. Yeah. So basically helps you eliminate your excess ammonia that is getting formed. Okay. Now, supportive measures. By here, supportive measures, I mean that ascites है, so ascitic tapping or putting in uh, tube to drain excess of fluid if it is becoming very recurrent. So you can get a tube inserted in the abdominal cavity as well. So, those sort of things. So pigtail insertion basically. So all sorts of things can be done as supportive measures. So if he's having NCAF, then giving them reorientation measures or helping them manage all those symptoms as well. So those are the supportive measures that you'll go in for. Right. Okay. Now coming to renal diseases. So you have basically your end stage kidney diseases. Symptoms again overlap with that of hepatobiliary. So you have a lot of nausea, vomiting, you have your decreased appetite, fatigue, urine output is getting reduced. So there are, if no fluid restriction, then fluid overload will happen, which will present with edema, chest pain, breathlessness, and headache. You have pruritus here again, and you'll have muscle twitches and cramps and sleep disturbances. Now, coming to symptoms, all these symptoms, what would be the drug of choice here for nausea, vomiting? So here it's because of uremia that you'll have nausea, vomiting. So again, anything that is centrally acting would be beneficial. So ondansetron would work or haloperidol would work very nicely here as well. Pruritic agent here, what would be your drug of choice? So sertraline is specifically first line for hepatic cause of pruritus. Here in renal cause, it would be your UVB light therapy. So UVB light therapy will work better here, or local application of capsaicin. So wherever there's a lot of itching, capsaicin application helps. Or dapsone is another choice, drug of choice, or ondansetron. So ondansetron will be preferred here, whereas in hepatic failure, that is a third line of management. Laxative, again, here lactulose is preferred, and supportive measures wherever necessary. Coming to breathlessness per se, because this is the second most commonest symptom that you see after pain. So here is the breathing, thinking, functioning pattern of breathlessness. So what they postulated was that breathlessness is not just because the physical aspect of it. It is because of the inefficient breathing pattern. It's also because of the thoughts and misconceptions that they have of the said breathlessness and the functioning of the whole person in a whole. So it's because of the deconditioning of the limb, the chest wall muscles, and everything. So all these leads to a lot of breathlessness and a lot of distress associated with breathlessness, which makes it into a vicious cycle. So managing breathlessness properly, you have to target all of these together. So you have to make it an efficient breathing or efficient way of breathing. You have to lies their anxiety and distress associated with that breathlessness, and you have to help them rehabilitate about the functionality as well. So, um, uh, you know, paced workouts or paced energy outputs, encouraging exercises that should help with the functionality. ठीक है? So it's not just बहुत breathlessness है opioid दे दिया उससे हो जाना चाहिए. So that is not the end of it. You have to help them with their thinking pattern and their functionality as well to manage breathlessness efficiently. Someone just raised their hand. Is there any doubt or question? So coming on to end of life care management. Now, this was given by the Indian Society of Critical Care Medicine. Now, this one is a bit older. The newer one is still in process, but or it's been published recently. So basically, what they said was that if the physicians feel that the ongoing treatment is not uh, helpful or beneficial for the patient, um, they should have a consensus among all the physicians involved. Then they should offer all the available options to the patient slash patient's relative or caregiver. If they are agreeing to it and there is an institutional ethics board who also agree that this should be the course of line, then they should be given the option of withholding or withdrawing of care. And then making sure that all the symptoms are properly managed, and they should be able to die in peace or in a way that is dignified. So that was the whole uh, end of life pathway that was put forward by ICCM and Palliative Care Association. So it has been upgraded. So because of the recent Supreme Court judgment, it has changed quite a bit. Now they have to have two committees, level 1 committee, level 2 committee, who should both agree that, okay, this particular um, treatment is futile, and thus we are going for withholding or withdrawing of care, which is a tedious process, but it's better than what it was previously. So that's a step forward. So basically what it entails was that any person coming from anywhere, so it might be emergency department, might be wards or ICU, if there is prognostic uncertainty, it's in consensus with all the physicians who are involved. This should be disclosed to the family members or the patient directly, honestly and early. And we should establish what their goals of care are, basically. And if they are feeling that they should not go for any further escalation of care, or they should withdraw whatever care is being given, that should be allowed with effective comfort care or end of life care management with proper symptom management. And they should be able to die in a dignified manner. Now, this is what the gist of the whole thing is. And it should be documented at every step. And the patients or the relatives should be given the option that if at any time you feel uncomfortable with this, you are allowed to take away that consent, and you can continue with whatever care has been going on. Now, this was the road ahead is quite hard because, as I said, in non-oncology, it's difficult for the physicians and the patients to understand their severity. So, and the trajectory is very confusing. So you are not able to pinpoint that this would be the last event which is going to be severe enough to account for end of life care. So you don't know whether this is the last event or not because the trajectory is very haywire. The It's not as straightforward as cancer patients. The symptoms are also vary from time to time. So he might be severe enough now, but he might come to you 1 month down the line, he's absolutely fine. So the symptom profiles are also very confusing. So it's a long way ahead, specifically in non-oncology setting, but let's hope that we get there sometime. Thank you. Any questions or any discussing points you might have had in your your experience as well?
Thank you, Rutula. They, like anybody, like I said, if somebody wanted to speak or ask, they could unmute and speak also first. Thank you once again, Rutula, for taking us through in a methodical fashion, covering all systems. And as Rutula mentioned, regarding this end of life care, little bit more in detail we'll do in the end of life care session, where there are still some prognosticating index or scores which can be used. Even though, like, see, in oncology, there have been many studies which have shown that, for example, a patient is like, for example, 75-year-old you get, but one patient has oncology and one patient is a non-oncology patient. In those situations, the prognostication and decision making are more appropriate or close to in numbers in oncology, whereas in non-oncology it may be like a range. So for that also there are some index which you can use, in which you put all those salient factors, and you will be able to get to a decision there also. But as I said, it will be in a range which you can explain to the patient and family. So that will be dealt with in more detail when we go and do the session on end of life care. And regarding this, thank you very much for bringing up that breathing, thinking, functioning model. That's again a very important thing. That also will be dealt with in more detail in the respiratory session. So those two will be covered, and but system wise, this is an important thing. And one more thing which I want to reiterate it, as Rutula mentioned in that four roads to death, that third graph, we just have to explain that important factor. Like, see, every time they have an episode or an incidence of either an infection, re-exacerbation of their condition, they get better, but they don't get better to the state where they are. She said a nice word, that's their new normal. So these are things, it is the duty of the parent physician or their family physician or their regular physician to inform the patients. Because see, in today's world, infectious disease is not the issue, non-communicable disease. All of you will be seeing patients. For example, diabetes mellitus patient coming to you for last 20 years. So first maybe walking, then walking comfortably, walking with like using a stick, then using wheelchair. See, that is a thing, but for them, that's what, see, again, no assumption. Yesterday we all had, like in the last session we had, like, don't assume anything. And then, so if you don't assume that the patient knows or things, or don't assume that the patient does not know. So have a conversation to find out. So they themselves will tell, see, slowly I've realized that I've become more dependent. I can't do things by myself. So what has that impacted? So utilize these opportunities to explain. That's all. You're not enforcing anything on anyone. So utilize the opportunities to explain. Then in those stages, and the family physician or the parent physician has the highest chance of introducing and explaining palliative care to the patients. So utilize that opportunity. So anybody wants to ask anything? 1 minute, let us check anything else in the chat. what were the responses which were there only are there, I think. Okay, in that case, let us go on to the case discussion, case presentation, and then we can have the any other discussion to be done also. Once there's one or pause stage, do we start palliative care for? Do you want to go ahead and answer, Rutula?
So it would ideally, they say that it should start at the diagnosis, but it is quite illogical to do it because it's just starting off. So, but once I mean, it requires a lot of awareness programs as well. But once you feel that the symptoms are increasing despite optimal or increasing the medicines for the said disease, it's good to kind of have a consult with a palliative care physician just to see whether they can, manage the symptoms properly. So, and unfortunately, there are no kind of tools which would help to pinpoint at which stage those patients should be referred to palliative care. And that's an area for research as well. For COPD or ILD, like, let's say despite all the medications, the patient is still breathless. You can refer for, palliative care. Maybe they'll start off with, let's say, morphine. They start him or her on morphine. What happens is that the symptoms reduces. This leads to patient having more functionality plus more adherence to the ongoing treatment as well. So it kind of overall helps the patient be better or be managed better. And the small study which was done in our institute showed that their quality of life also improved with that. So, it's kind of beneficial in general. So at the point where you feel that, okay, this patient would benefit from a consult, that time. Training of members of the family in what, and like anything particular or what regarding the they should be made aware that this is a chronic disease, and that the health of the patient would deteriorate over time. It might be very slow and it might take ages and years at end, but they should be told that this is a chronic disease and it's not a curable disease, it's a progressive disease. That is what we fail to do most of the time, that we don't tell them that it's a progressive disease. We just tell them, ye dawai lo, theek ho jayega. And you do feel better. The symptoms go away, especially in the beginning stages of all the diseases. The symptoms are very mild or almost not there. So they should be made aware that the chronicity of the disease should be explained to the relatives. And basic care about, ye karna chahiye, nahi karna chahiye. It'll differ from like disease to disease, but let's say sticking on to COPD and ILD, so wear masks wherever you go. So basic training, basic, not even training, basic knowledge should be imparted to that, just for prevention of any further exacerbation or any further deterioration. So all those small points should be discussed.
Thank you, Rutula. I just thought of adding a couple of things to that. As Rutula mentioned, that the way how to pick up is one is like using like same respiratory COPD ILD is the example I was also trying to come to. See, more inhalers used, for example, someone was using 2, 3, 4, 5, you go, still no response. Or so the symptom or their daily activity, even for speaking, I'm becoming breathless. So the worsening of the condition and then no response or decreased response to the same medications what they were using. So again, that is underlying disease progression is what is externally shown through the symptoms. So utilizing that as the marker to see how they are going. And number of admissions or number of episodes within 3 to 6 months is another important thing you can see. Recurrent, within 6 months, 4 times they were admitted to intensive care, or they had 4 severe episodes. Before they used to get 4 episodes in 1 year, now 4 episodes in 3 months. So something like that can be used. And so another thing is that this breathing, thinking, functioning module and all, I am not telling, not that everyone. See how much everyone, this palliative care approach, how much a general physician is also using, I am not aware of. Okay. So that the various, pharmacological, non-pharmacological options are there. So many non-pharmacological options are there. You've all had these sessions, even for pain, even for breathlessness. So are these all practiced and told to all patients by every physician? I am not aware of. So at least the options are open. So they're referring to a palliative care physician. If not, or if someone trained will help the patient with more options and have a better quality of life. So those are things. And regarding training, that is what is raising awareness for the family and caregivers and the patient. So raising awareness has to be done both by medical professionals like doctors, nurses, everyone. And for example, that is one thing which Palliative is doing. There are training programs for volunteers. No one needs to be a doctor or nurse to attend that program. It's a 5-day program, which some of my friends have really said, this is something very good. All of us have elderly at home. Who in this group, can someone tell me I don't have any elderly at home? I used to say I still have some, we used to have 80 plus, at least 6 or 8, 80 plus at home. So that is normal. So nothing wrong in everyone being aware. So those type of, already Palliative does some programs like that, which anyone is interested in. It's just a 5-day program. So raising awareness is also possible, and that can be done for everyone. So that can be one. So, and also there are training, like caregiver training also, caregiver training, caregiver awareness, all those are done. So for long-term illnesses also, they are done. So have I answered? I think it was Dr. Premnath who asked about it. Is that right? Have I? Refractory to treatment? Yes, that exactly. That is what we were telling, as picking up at that stage when they get to that stage, that referring to palliative care. Or at least telling them and introducing them the option of palliative care, and so they can think about. So, but when we are telling about this graph 3 inroads to death, that when deterioration is happening itself, you should introduce. Only then, when you introduce that, they will start thinking, and you're giving time for them to come back. Because see, in all these we have seen, there are phases. Everyone doesn't want to accept. So the denial phase has to be overcome by the patient and family. And death is also a natural process. They have to slowly understand that, and then only acceptance will come. See, acceptance is the last thing, as we saw. But again, back and forth. These are all not clearly demarcated. So utilizing the time and then going with the flow with the patient and doing it. Is that okay? There are no more questions in the chat. So then, Sangeet, we can go with the case discussion, please.
Okay, ma'am. So presenter is Dr. Fatima Hanina. I welcome now.
Good evening, all. Am I audible?
Yes, ma'am, you're audible.
Yeah. So I'll start my presentation. So my patient is a 62-year-old male with a diagnosis of traumatic spinal cord injury, sequelae tetraplegia, neurological level of injury C4, with Asia impairment scale of A, who's a known ankylosing spondylitis patient with chronic kidney disease on hemodialysis, he had a history of coronary artery disease and underwent a percutaneous intervention 1 year back, and also hypertensive. So presenting complaint was he presented with weakness of all limbs on April 2nd, 2024 after a fall. So history of presenting complaints. He is a known hypertensive, ankylosing spondylitis and CAD patient who had cardiac arrest in Jan 2024, who was undergoing dialysis thrice weekly. He was premorbidly ambulant and independent in all activities. He had a sudden onset of loss of consciousness and fall on 2nd of April, followed by he developed pain over neck and loss of sensation and weakness of both upper and lower limbs. There was no history of headache, vomiting, or seizures. His MRI C-spine showed a transverse fracture of C5 vertebrae causing transection of the body with marked translation of the C4 vertebrae over the C5 with bilateral facial dislocation at C4, C5 and marked spinal canal stenosis and complete effacement of the thecal sac. With posteriorly displaced C5 vertebral body impinging on the spinal cord with disruption of the posterior longitudinal ligament. He underwent posterior instrumentation and fusion of the vertebral body, that is C2 to C7 on 3rd of April, and followed by tracheostomy insertion on 3rd. Then he's been feeding on nasogastric tube. And he's on ventilator, and we find difficulty in weaning off ventilator because of multiple episodes of desaturation, because of tracheostomy secretions and the tube block, and also pulmonary edema before the hemodialysis. Next slide, please. So on examination, his BP is 150 bar 180, but it used to fluctuate because of the autonomic dysreflexia. Heart rate 88, saturation is 98% on CPAP. He's E4 M6, sorry, it is not V5, it is VT. And his power is shoulder 1 bilateral, elbow flexion 1 bilateral, elbow extension 2 on right side and 1 on left side. Rest all the muscles he is having 0 power, and his sensation is intact till C4 neurological level, and it is impaired over C5 and absent from C6 and below. Next slide, please. So this is his MRI picture. We could see there is a complete transection of the spinal cord. His bloods, the counts are normal at present, like 11,400. His HP used to fluctuate like 6.4, 7.6, and 7.7 according to the dialysis, and sometimes it used to be corrected in the dialysis. Electrolytes are also fluctuating, and it has been corrected after the dialysis. Creatinine is 7, and now currently it is 3.6, albumin 3. Next slide. So he's undergoing hemodialysis thrice weekly. Our plan was to convert him. The nephrologists are planning to convert into a peritoneal dialysis, which is being discussion is going on with the family and the patient. The urine is drained by a Nelaton catheter once in 2 days, because it usually happens only 100 ml. He has occasional mild shoulder pain, so we had given him trigger release as well as tramadol injections. Bowel opening is occurring daily with laxatives. He's been mobilized to chair daily. He's tolerating around half an hour of sitting. There is no postural hypotension. He's been planned to change to a portable ventilator at fixed duration. And our goals for him is to mobilize him in wheelchair and also transferring from bed to the wheelchair by a hoist. Psychological aspects, he was working in a private firm. He was having a desk job, which he discontinued once he was diagnosed as chronic kidney disease and was started on dialysis. His wife is retired from Airport Authority of India. He has a one son and a daughter, both are doctors. there is no financial constraints at present because everything are insurance covered. And he looks depressed and tired, and we offered a psychology as well as psychiatric help, but family declined. Next slide. Currently, he's on medications like erythropoietin, atorvastatin, nebulizations, heparin for prevention of deep vein thrombosis, clopidogrel and ecosprin because he was having CAD before, pregabalin for neuropathic pain, tramadol 50 mg PRN, and Pantop and bisoprolol is being used as laxative. Next slide, please. Main concern is we, after attaining the goals, we are planning for a transition to home, but family doesn't want, and they want to continue at hospital indefinitely. And patient when we ask the patient can only communicate by gestures and also eye movements. He look upwards for yes and closes the eyes for no. And as per however he could communicate, what he said is that he wants whatever is safe and whatever his family and he agrees to whatever his family wants. Next slide, please. So summary, we have a 62-year-old male who is a known CKD on hemodialysis with ankylosing spondylosis, developed traumatic spinal cord injury, sequelae tetraplegia with neurological level of injury, C4, underwent post-spinal fixation on ventilator and Riles tube feeding. Next slide, please. So the points that I wanted a clarity or discussion is regarding the transition to home, because we have family who is not willing to go home. It is what to be done, or whether we have to, because it is difficult to continue in a tertiary care setup prolonged. They are having insurance which is being covered at present. And for dialysis also, if we are converting into peritoneal dialysis, they have to go home, and which is not covered under insurance. So after today's class, I don't know whether they are in a denial or whether we have to go along what they decide, but that is not a practical solution as well. That's all.
So any particular, can you hear me?
Yeah, please.
Okay, so any particular reason why they are not willing to go back home?
I think it may be like one is the dialysis, because every week, like weekly, it is thrice they have to come for dialysis.
Alternate day mostly.
Yeah, and he is a quadriplegia. Shifting is difficult, and he's on ventilator. Maybe these all things.
Okay, so apart from that, nothing. Like usually the concerns stem from who will be the one taking care at home, because there'll be positioning, positioning would be hampered and everything. So
Yeah.
I
No,
mean,
because his family is very cooperative. His wife is there with him, and also they could even afford a caretaker because we also don't want the wife to be the primary or the sole caretaker. Based on her quality of life also. So we even suggested a caregiver. Actually, currently they have a caregiver also, a carer to take care of like positioning and all.
Okay. And what about the goals of care? What are their, are those identified?
The only issues pending is the ventilator, because now what we are looking is to keep a definite time for ventilator, so that it is easy for them to go home with the portable ventilator.
Okay. So if that is sorted, has the option of peritoneal dialysis ever explored with them?
Yes. That also has been, we have, like we used to have a multidisciplinary meeting, and
Right.
we explained the same to them. So they were like, we'll think about it, and it's been like, and finally they told like the issue is that they cannot cover that under the insurance if it is being done at home, and it will be around 50,000 per month per week for peritoneal dialysis. So they are having difficulty to find that amount.
And I mean, there is no cap for the insurance, like they can indefinitely stay in the hospital.
At present, yes, because it is accordingly how we give the prescriptions or how we explain the status. And I think they are also looking for other insurances also.
And any facility nearby the house where they can get the hemodialysis? If
Uh,
required.
I have not inquired that. Maybe that is an option which we
Yeah.
could.
So, somewhere nearby, or if you have the facility of a nursing home where dialysis is also available, or they have a place where they can do the setup. So that is another option. Then because caretaker and everything is all else taken care of, like they can afford it on their own. So that is not the issue that we're dealing with here. It's more about transferring in the patient because it's quadriplegic. So transferring from home to hospital, that too thrice a week, which would be tedious. I mean, logically speaking, it'll be better if he stays in the hospital because he does not have to move that often. But the other option is nursing home where he can. So it's a step down from a tertiary hospital to a nursing care facility. Peritoneal dialysis is another option, like so they can stay at home. And I mean, other ways you can tell them what all are the effects of prolonged hospital stay as well. Like the chances of infections would increase, chances of the complications might increase, and maybe re-establish what their goals of care are. So if they are going for complete palliation, then you might even want to taper down the amount of dialysis that they are going through. That is another option. And again, depends on how well the patient is. If he's apart from all this, if he's absolutely fine, then tapering down the dialysis would mean, shortening his life purposefully. So it'll all depend on his performance status at the moment. You'll have to prognosticate him how about the expectancy, life expectancy, and then maybe figure out the goals of care of the family, get that in alignment, and then discuss what are the options that are available. So continuing in the hospital versus nursing care versus home. So maybe discuss all of them. That also discuss that despite having insurance, there would be financial constraints down the line. So which option would be more beneficial should also be explored. Like them staying in the hospital for 1 month with the current insurance money versus them taking let's say peritoneal dialysis at home for the next 3-4 months, which is more economical. Because I mean, I'm assuming the insurance is for the family in general. It's the whole family that the insurance is there. So I mean, for emergencies, they should have a backup with the insurance for the rest of the family members as well. So we'll have to discuss those financial aspects also. So we explore everything and then maybe try to gently. I mean, you cannot say ki jao abhi jana hi hai. So what they feel is that you
Yes,
are kind of abandoning them. Like just go away. So that should not be the case. They should be like, we are thinking for you, and we are trying to understand what would be more appropriate in this situation. Try and explore all the options, maybe. Yeah.
Yes, Rutula, thank you for taking it through in a methodical, in a stepwise. See, basically, you have to go back. I was also thinking, how long, a few questions, how long the patient has been in hospital and what was his quality of life before he came into hospital?
He was admitted on April 2nd. Like it will be around 1 month and maybe a week more. And before he was constrained to home itself, like because of his kidney disease, he doesn't go out much, but he was independent in all his activities.
In the sense, was he work? He's 62-year-old years, isn't
Yeah.
it? So, and you said he was only at home.
Yeah.
Was he able to do all his no help required?
No help.
And how was his How was his kidney parameters before coming in? Did he need dialysis?
Yeah, he was on
Mm-mm.
dialysis for last 5 years.
Ah,
Because of his
okay.
dialysis, he quitted his job. He resigned his job, and then his outgoing was also limited. Like he doesn't go out much. He's within the house, but he was independent in all his activities.
Okay, so the CKD was already needing dialysis 3 times a week was the
Yes.
pattern before this episode.
Yes.
Okay, so home, not going out, was at home doing his ADLs.
Yeah.
Now he has come to a stage where he is unable to do anything for himself.
Yes.
So as Rutula mentioned, no, so you have to, it is now nearly 5 weeks roughly from what you say.
Yes.
So, so the 5 weeks deterioration. So this, it is a bit too early for them to accept, but our job here is to explain everything to them. Disease trajectory, and then already because of a CKD, this dialysis minimum 3 times is going to be there, or it may only increase. So dialysis options, then insurance coverage, they have to go back and forth to the insurance also to know, you're telling everything is covered now.
Yes.
But if this insurance is only husband wife, or do they have any more children, family?
Yeah, they have 2 kids. Both are doctors.
So that's all. So those things, disease explanation, financial explanation, and goals of care have to be reiterated. They have to discuss among themselves or what, and then if make another discussion on all these 3 points. And think of suggestions. See, peritoneal dialysis, when you think of insurance and financial options, no, you can go through what are the options for the same amount, different things. If you can prolong the dialysis period for the same amount of insurance, those type of things, no, they have to go back and forth with the insurance and find out. So goals of care and financial thing, and those two to be goals of care and disease trajectory to be discussed between us and them, and financial things they have to discuss and come back, and then with 1 2 connect the third one and then move forward, and look at options like step down care, we will say. Because see, from here to home they may be scared. If there is something in between, where if there is a place where for lesser cost dialysis can be done there, or they can stay there, that if that option is there, a facility which has dialysis but not a tertiary place as your hospital. So because if you do like that, it may be a gradual step down, so they may be prepared both physically, mentally, and financially to move in that path.
Yes, ma'am, we have to explore that.
And then that you like, have you had any like psychologists to understand? Have you made some discussions with them to make sure, as we always say, to find out whether they have understood what you're telling?
Yes, we actually sent a psychologist, and also we asked for a psychiatric help. But the family were like, we don't want at present. So they declined it.
See, psychiatry, not a psychologist, will be helpful, because to find out, because at least we have to find out all what you're telling, whether they are gathering, and that's why, as I always say, I've been telling this, you have to ask them to tell back few things what you are telling, so then you will know whether they are understanding. Now you said there are 2 doctors in the family, so it is not an easy task. So just to make sure that what you are conveying is understood and accepted. So goals of care and things have to be made, step down care, and then if financially if they are happy for everything and all, no, then you have to think of other facilities for where these type of care can be provided. Because as long as your hospital is happy to have them, they will be willing to continue there.
There is high risk for infections because he'll have one or the other infections when we continue.
Exactly. So that you have to explain, because see, every time infection is deterioration. That graph 3 you will have to explain. So that is something very useful one. Explain once, and then they themselves will, they can, if you tell them, they will see the difference in the patient also. Infection, condition, and how things are. Is there anything like this being discussed between the husband wife before this episode? Like any advanced planning, advanced directive, anything like that? Any discussion husband and wife have had, anything like that? You can ask also.
Okay.
Because he was already not very well, no?
Mm-hmm.
He was on dialysis 3 times a week.
Yeah.
See, because sometimes it is worth asking, because any wish has been said or anything has he expressed.
I don't think that there would be something, because we had a discussion with the whole team and the family and all regarding how to continue and all, and they were like they want to continue to every extent, and they would be happy if they could continue here only, and the issues were these dialysis and all at that time.
Okay, because see, continue everything is what everyone will tell. Are not knowing what are the consequences and things like that. But as I said, it is worth asking if they have thought anything about it. If not, no.
Definitely.
That's all. Just to make sure everything is covered. That is the main thing. Okay, thank you very much for bringing up this case. Because these are things, no real hand-on issues which you have to face on a daily basis. Okay. Sangeet, we can just come out of this presentation. And there were a couple of questions in the chat box. Charitable dialysis centers are available in many cities. See, that's something, as I said, no, if something like that is there, they can think of. In this case, what is the role of palliative care team? Rutula, go ahead first, then I will.
It is also like kind of making it a more holistic approach. Like you are the point of contact for every department which is coming in, and you are the spokesperson for the patient per se. And also to make it more easier for them to manage, not only in the hospital but also if they're thinking of at a nursing home or home. And maybe it is more just being there for the family and the patient as well. So, and the symptoms, of course, whatever symptoms might be there, those are getting managed. So I think that would be the role in this particular patient.
Thank you, Rutula. See, as we always say, multimodal approach. Yeah. That's where palliative care team is going to be helpful. See, palliative care team will have, will have a psychologist and a social worker, okay, who can do big scale work in this particular case, if you ask me, okay. Because psychologists, already she said that they were not willing. So directly, initially, no one will be willing, because these are all inborn, like innate qualities in human beings that we all want to live only. None of us want to give up. So the psychologist can have few sessions. Initially, they will say no, okay, but their mood, even the 6 weeks, 5 weeks to what he was and what he is, 5 weeks is enough of long time, okay. For anybody else, it may not be long. For the wife, it will be a long time. Okay. So slowly, if they have few 1 or 2 sessions with her and talk, she will open up. So the role of psychologist will be helpful. And because it is to see, that is why what is the definition of palliative care? Life-limiting, life-threatening, or any serious health-related issue, alleviating suffering for patient and the caregiver also. See, already this patient is C4 5 level. But for the ventilator, he won't be surviving. No, that's for diaphragm supply. What is the diaphragmatic nerve supply? So the ventilator, so like that, no, not that we are telling. So as long as they can afford, they can carry on giving ventilator, carry on doing dialysis. Okay, then comes the quality of life. So all these beings should not enforce anything like that, only giving awareness. So psychologists will be very helpful. So it's still continuing all symptomatic support, and the social worker will help them in other aspects also, financial, psychosocial, all. So a multidisciplinary team approach and multimodal management, I think, can be done from a palliative care point of view. Again, no, for that first willingness from the family also has to be there. So again, awareness. So it is not, nothing is easy. But if you sow these seeds, we say, slowly it will transform and change. So that's what effective symptom management. And if, like, see, as Dr. Premata said, no, if there are some charitable centers, so continue dialysis. And then only the other issues, as long as they are in hospital, no, it is different. But things also, you have to, disease trajectory and things have to be explained to them few times. That is where, no, as we have been telling, 1 sitting, 2 sitting may not be sufficient. So it is patient, our patience also has to increase, and then that is where the palliative care team will be helpful. So the parent team may not be having enough time, so the palliative care physician may be able to help them to explain, and then the psychologist and the social worker can do their role also, and collectively it can be done. And maybe once in 2 weeks or 4 weeks, you have to revisit the goals of care with the patient's condition. Anything more you want to add on, Rutula? Can't hear you, dear.
Just revisiting or re-exploring their goals of care along the way. So maybe not daily, that will become too much and they'll be like, you disturbing us daily. But maybe once or twice in a week would be just revisiting their goals of care, re-exploring it.
Anybody else wants to ask anything or want to, someone differs from what we have discussed so far? Okay, then in that case, a big thank you again to Rutula and for the case presentation to also. I'll hand over it to Sangeet.
Thank you, ma'am. Thank you, Dr. Rutula, for the wonderful presentation. Thank you, Case President Fatima Hanina, for presenting the case. Thank you, Radha ma'am, for facilitating the session. Thank you all for joining. Thank you. Let's see you in the next session. Bye.
Thank you, everyone.
Bye.
Thank you. Bye.
Thank you.
Thank you, Rutula, too.